Start. Welcome, everyone. Welcome to the first Friday in February webinar, Global Elimination of Viral Hepatitis for Liver Cancer Prevention. A perfect presentation today is expected on World Cancer Day. Today is World Cancer Day, so I think this is a very appropriate presentation for today. Let me just give a couple brief remarks and then introduce the speaker, and then we'll get right into it. So I'm Dr. Rob Murphy, and I'm the Executive Director of the Havey Institute for Global Health, and John Philip Fair, Professor of Infectious Diseases and Professor of Biomedical Engineering at Northwestern University. Thank you for taking the time to join us this afternoon for our latest installment of the Havey Institute for Global Health First Friday Seminar Series. Please take a moment at your convenience to follow us on Facebook and Twitter at #FSMGlobalHealth. In addition, we welcome you to become an Institute member to receive access to specialized resources and services that support research infrastructure. Has all our information about the Institute up there. And for more information, you can check out our website, which is a pretty simple address, globalhealth.northwestern.edu/members. Today, we are thrilled to have Funmi Lesi join us for a timely discussion on global elimination efforts of viral hepatitis for liver cancer prevention. Let me give you a few some background information on Professor Lesi. She currently leads the hepatitis team in global HIV, hepatitis, and sexually transmitted infection programs at the WHO in Geneva, where she coordinates hepatitis activities and provides technical and strategic support for the implementation of hepatitis B and C testing and treatment programs worldwide as part of the global elimination strategy. For over 12 years, she served as head of Gastroenterology and Hepatology unit and professor of medicine and consultant hepatologist at the College of Medicine, University of Lagos, and Lagos University Teaching Hospital, where she established a liver disease clinical care and treatment program for viral hepatitis and liver cancer and contributed significantly to gastroenterology and hepatology fellowship training in the West Africa sub-region. It's also note that Northwestern has had a long-term relationship working with the University of Lagos actually since 2002. For over 12, oops, I already said that. Funmi also served as the WHO Africa Regional Advisor for Viral Hepatitis Elimination, where she facilitated public health clinician community collaboration in over 22 countries, promoting a public health approach to viral hepatitis control and providing support for the establishment of hepatitis elimination programs. Her research priorities include liver disease and hepatocellular cancer epidemiology. So we will have time for questions following the presentation, in which you're welcome to submit your questions through the Q&A feature. Please use the Q&A feature, not the chat feature. It's better to do the Q&A at the bottom of your screen. And we will take the questions after the presentation. So now, Dr. Lesi, I turn it over to you. Thank you very much for joining us today.
Thank you very much, Rob. And I'm really, really honored to be here today. I hope you can hear me loud and clear.
Yeah, we hear you fine. Thank you.
Okay. So I have no conflict of interest to disclose today, but I would like to sincerely appreciate the work of Northwestern in liver cancer epigenomic biomarkers in Nigeria, especially Rob Murphy, Olufunmilayo, and the team. And I deeply appreciate my colleagues at WHO, at the HQ regional and country offices. And just a quick talk through the overview for today. Why are we talking about liver cancer? Why does WHO have a global hepatitis policy for elimination of viral hepatitis? And how do we translate this policy to practice? Are some of the things we'll be addressing this afternoon. Today is World Cancer Day, and it is really appropriate that I commence this conversation on liver cancer. Liver cancer, we know, is cancer that occurs in the liver, and it can come primarily from liver cells, and it's called primary liver cancer, or it may come from other structures or other organs, in which case it's known as metastatic liver cancer. Hepatocellular cancer is the most common type of primary liver cancer, and it's a major cause of morbidity and mortality worldwide, with nearly 1 million deaths per annum. Now, over 80% of these cancers occur in sub-Saharan Africa, Southeast Asia, and East Asia. And of course, like I said, 3/4 of them are attributable to chronic hepatitis B and C. And that means that countries that have a high prevalence of these infections usually have a high incidence. Indeed, liver cancer is the 6th most common cancer worldwide and the 3rd leading cause of cancer death. It has the dubious distinction of the shortest survival time in both men and women, with an overall mortality to incidence ratio of 4.9%, which means that when they are diagnosed with liver cancer, shortly afterwards, the death rates are pretty high. So liver cancer has been one of my clinical and research priorities, and I've had the opportunity to lead the care of several hundreds of patients with liver cancer. I wish to begin by highlighting this particular collaborative work, which we have conducted as part of the African Hepatocellular Consortium with Professor Louis Roberts at Mayo Clinic in Rochester. It was published in 2017. And it's a multi-country collaborative where we obtained information from over 2,500 liver cancer patients from 10 countries, including Egypt, Nigeria, Ghana, Ivory Coast, Cameroon, Sudan, Ethiopia, Tanzania, and Uganda. And some very interesting observations from that study. Half the participants were from sub-Saharan Africa, and the other half was from North Africa, specifically Egypt. And it's interesting to look at the characteristics of both groups as they were different. They were both predominantly male, but other characteristics are shown below. The patients from sub-Saharan Africa were younger, so they were mostly in their mid-40s. And hepatitis B and C, especially B, was the predominant infection. Most patients presented with advanced cancer at an inoperable stage, and less than 3% of the liver cancers in the African patients had access to advanced technological care or liver transplantation. And sad to say, most of the patients died within 6 months. Now, in contrast with the patients from North Africa, they were a decade older and were more likely to have hepatitis C, and over 75% of them had access to specific therapy. And I'd like to pause here for a minute to reflect at the clinical bedside of liver cancer in Nigeria. So we know for sure that patients come with advanced liver cancer mass, presenting with large abdominal mass. And at the bottom of the screen on the right is one of our patients who had liver cancer. And I could not resist but take this picture because of the huge abdominal mass we saw at first presentation. The outcomes are usually dismal and distressing, and patients incur catastrophic financial expenditures. And there's a lot of frustration of care for both the patients and the healthcare workers because of the lack of advanced technological cares. Now, the important thing I'm trying to bring out here is in our early studies of liver cancer 20 years ago, this was exactly the same presentation, late presentation, high mortality. So to summarize the African liver cancer experience, there's been little change in outcomes over the past 20 years. From an advanced country perspective, the availability of liver transplantation and other therapies have prolonged survival by 2 to 3 years. So I guess that overall, it's a dismal outlook for liver cancer. And it'll be great to hear some of your thoughts or experiences if you've ever had patients with such kinds of diseases as liver cancer. So why does WHO have a global hepatitis strategy for hepatitis elimination? For several reasons. Now there's a shift in the focus to prevention. And for me, that means moving upstream in the pathway. So recognizing viral hepatitis as a global health, in 2019, viral hepatitis mortality was shown to be on an upward trajectory. And you can see in the graph on the right in the yellow line, the number of liver cancers was approaching or exceeding that of HIV and other infectious diseases. Of course, this talks to the success of the global HIV response and the diminishing death rates of HIV. However, it brought up the increasing trajectory of liver cancer. So focusing on viral hepatitis, the liver mortality occurs 2 to 3 decades of chronic, untreated hepatitis. And this provides a window of opportunity for definitive action to reduce the mortality. In addition, in the past decade, there has been significant technological innovations that simplified testing and diagnosis for viral hepatitis. And of course, we know about the transformational hepatitis C therapy with DAAs, with cure rates exceeding 95% within 2 to 3 months. That has really revolutionized hepatitis C therapy worldwide. Again, we know that effective hepatitis B therapy with possible lifelong treatment reduces the risk of mortality and liver disease. So the World Health Assembly recognizes viral hepatitis as a threat to development and endorsed WHO's first ever global health sector strategy on viral hepatitis with its ambitious targets, which defines elimination as 65% reduction in deaths, as you can see on the right table, and 90% reductions in new infections compared to the 2015 baseline. This was really key early milestone in the hepatitis elimination story, and it called for a paradigm shift in hepatitis care and a public health approach to treating hepatitis B and C away from a purely specialized care approach. The strategy also identified by modeling 6 synergistic core interventions across prevention and treatment, which can be scaled up to reach elimination. These interventions are shown on the table at the bottom of the screen. So it serves as a normative guidance that serves as the basis for national policies and country-specific adaptations. So in the last 5 years of this strategy, there have been some achievements and gaps. And this table shows the new hepatitis B and C infections and mortality and the hepatitis B prevalence among children. What is striking is that the hepatitis B prevalence among children under 5 years of age was 0.94% and this hit the 2020 targets, even though that there are many children in sub-Saharan Africa who are yet to get a birth dose. We see also there was 1.1 million deaths and 3 million new infections. On the right panel, we see the huge gaps in diagnosis and treatment of viral hepatitis, despite this transformational DAA therapy and the rapid uptake of treatment, which really exceeded the pace of HIV when the infection became a public health response. So scaling up HIV, hepatitis, and STI responses has the potential to save 2 million lives per year by 2030. Half of this death is due to viral hepatitis B and C. So the question is, how are we translating the global hepatitis policy to practice at the regional level? And the next couple of slides will highlight our initial work in the WHO Africa Regional Office in 2018 and 2019 before the COVID-19. Now, the red circle on this graph is the country of Congo-Brazzaville, and it may be a country we're not very familiar with, but that is the headquarters of the WHO in the Africa region. And this region comprises of 47 countries. And part of the work we did was to provide specialized technical support to the ministries of health in various countries and their partners in these countries. And some of the work we did include conducting country review and analysis of the hepatitis epidemic to improve and increase the awareness. This was done by country visits to various countries, at least 20 countries in this region, site visits to health facilities, some desk review of published data, as well as stakeholder interviews. The data obtained from all of these visits were used to guide the development of country-specific national strategic plans, which were aligned to the global strategy. And in some countries, we supported the development of an investment case for viral hepatitis elimination services and program establishment, and of course, the relevant capacity building. Also included in the work we did was establishing regional and national platforms for partnerships, for partner coordination, including with civil society and the private sector. This is another one of the initiatives that I led, and this is a situational analysis of 47 countries in the region to identify where the country is and the progress on the priority actions to reach the 2020 and 2030 goals and targets as laid out in the global strategy and in their own national strategy. The aim of doing this was really to see how countries were doing in these six core areas. And this scorecard was developed as a result of our results from this situation analysis and was presented in form of traffic light, where green shows target attained and yellow is the target, they are on track to reach the target, while the red is target not obtained. I know it's very small, but I think the important thing is to show that the greens and the yellows showed a lot of the vaccination goals were on track or targets were obtained. Now, what I've shown now in the red circle is the status of birth dose in 2018, where few countries had the hepatitis birth dose within 24 hours for newborns. This is also mostly red, showing that there were few testing centers that were separate from tertiary care. And this shows the mostly red where treatment was not available for hepatitis B and C. So in summary, there was still a lot of hepatitis care in tertiary and specialized centers, and very few had really adopted a public health approach. Two countries stand out, and that is Rwanda and Uganda, that actually commenced on widespread and wide-scale screening for hepatitis B and C. Now, recognizing the need for hepatitis data systems and surveillance, we initiated a specific project for assessment of the national surveillance for viral hepatitis across the cascade of care and the results framework in 6 countries as noted on the screen. And we initiated capacity building and development of the appropriate reporting system to address the gaps. Again, the methodology was based on actual country visit, site assessment, review of their surveillance systems and facilities, and the findings really are concurrent with some of what was shown in the scorecard. The childhood vaccination data in EPI was quite well reported, but there was an absence of public health data for hepatitis testing and treatment in 5 of the 6 countries, except South Africa. South Africa had a well-developed testing surveillance. There was no recording of liver cancer or cirrhosis beyond specific hospital facilities. Therefore, national governments cannot even estimate how much liver cancer they had. And cancer registries lacked adequate liver cancer reporting. And most of the cancer registries had surgical cancer reporting. And oftentimes, liver cancers are not surgically diagnosed, but they are diagnosed based on imaging. We also built capacity and partnerships and promoted a lot of advocacy and public health, physicians, clinician interaction with ministries of health and with civil society. So just to step back again and some reflections at the regional level in Africa. And what was common across many countries was the limited public and political awareness and limited collaboration. Of course, we have worked in African countries. We know that there are competing priorities with other infectious diseases and non-communicable diseases. I think one thing that stood out quite clearly is the traditional vertical programs with limited integration and limited cross-cutting activities. And this is really a lost opportunity to strengthen the health systems. Significant shortage of healthcare personnel is well known and limited data for advocacy. Unfortunately, there is no global fund for viral hepatitis. There's no PEPFAR for global hepatitis. So this was a program with negligible funding and lack of health insurance in many of the countries that we visited. So I'm going to move quickly now to some of the global priorities that WHO has established for measuring and reaching hepatitis elimination. So this is, in the past year, I've been working more globally and highlight here the focus of WHO's work in viral hepatitis. The focus is to convene strategies, targets, to advocate. And I'm just going to highlight some of the normative and policy work we have done in the past 1 year. And this is shown on the right. 3 things we've done in the past year is guidelines for preventing mother-to-child transmission of viral hepatitis, and then the validation process for elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B, now called triple elimination. Additionally, we have drawn up an interim guidance for countries who wish to validate viral hepatitis elimination. And this certification is due for 2030 for countries who wish to validate the elimination of viral hepatitis. Now, this framework was quite exciting, and the methodology was evidence-based, requiring several systematic reviews and modeling studies and global consultative meetings with experts all over the world, and Ministry of Health and civil societies. Some of the guiding principles are shown on the screen, that the process be country-led, and the idea is to motivate countries to place the hepatitis elimination efforts within a public health response. One exciting outcome from this framework is the development of options for validation of elimination of hepatitis B and C, and the options are shown. And I remember in HIV, we had various options for PMTCT. So for viral hepatitis, we have some countries may choose to start with an option A, where they address only hepatitis B, EMTCT, and this can be as part of triple elimination of HIV, syphilis, and hepatitis B. So the impact indicators are shown on the screen, and the program indicators, as well as implementation considerations and human rights considerations, and then they can apply to WHO for validation of elimination of hepatitis B, PMTCT. There's also the option B and option C, which is about addressing solely hepatitis C as a public health problem or hepatitis B. And in option D, it's an elimination of both B and C. And right now we're working with some countries and conducting country pilots to assess the feasibility of the criteria and the processes for viral hepatitis elimination. This is being done in 6 countries across the 6 WHO regions. And as you can see on the screen, we're going from Brazil, which is in the Pan-Atlantic region, to Rwanda in the Afro region, and other countries like Georgia in Europe, Egypt in the Eastern Mediterranean, Thailand, and Mongolia. On the right side are some of the impact measurements for elimination. And this includes the percentage of cirrhosis and liver cancer that is attributable to hepatitis B and C. And the idea is to measure and monitor global burden of liver cancer and liver cirrhosis as an impact target for hepatitis elimination. So just to talk about some reflections at the global level. And it's interesting at the global level that different regions have different challenges and different solutions. And therefore there is not a one cap fits all, different regions in different contexts. And what we can see here, some key lessons learned in achieving results in the different regions, from political leadership in Egypt, because Egypt has the largest HCV program in the world, to treatment delivery integrated in primary care and harm reduction in Europe, where there's a large pool of people who use drugs, and these people have a very high prevalence of hepatitis C. And we're looking at domestic financing within UHC, as is been done in India, where hepatitis is integrated to national health systems on the basis of economic analysis. In Africa, one of the countries that has been a champion country is Rwanda, where in 2019, over 1 million people had been tested. Other important issues at the level of global level include collaborations and partnerships and advocacy. And of course, to have global modeling, we need data. And this data is good for advocacy. Global donor funding has been very thin in viral hepatitis, and we seek donors for viral hepatitis elimination. The issue of stigma and discrimination becomes an issue, and inequities in hepatitis control globally. Also, of course, we know that the effect of COVID-19 has made a change. At the global level, it's important to learn from champion countries and previous experience, and learning from HIV response globally. The need for simplification of hepatitis treatment is clear. Countries like Egypt, where there's strong government leadership, the need for catalytic funding and integrated service delivery models are very important. And there's always a lot to learn from the ongoing COVID response. And sometimes we look at the response to COVID-19 and wish all diseases can be addressed like COVID-19's, or the remodeling of the health systems that is afforded by COVID-19 should present opportunities for other diseases. So we're looking at integration of diagnostic platforms. We're looking at vertical and horizontal integration, global partnerships, digital technologies, and there's a need to intensify efforts for vaccine development of hepatitis C. After all, the vaccine development for COVID-19 took such a short time. And of course, we need novel therapies for hepatitis B. This was a presentation that came out today. and I just thought I would share with you this presentation. It's a WHO Global Pulse Survey on continuity of essential health services during the COVID-19 pandemic. And the objective really is to provide a rapid snapshot of changes and challenges in service delivery utilization during the pandemic. The idea is to inform countries to support policy and planning dialogue and highlight critical bottlenecks. It's a modular approach that integrates all WHO's programmatic area into a comprehensive approach. And this is the third survey. The first was done in the third quarter of 2020, and the responses reflected situations during the previous 3 months. So what I'm going to show on the slide now is the Q4 2021 survey, which was done November, December of last year, and the responses reflect the situation during previous 6 months. So there are some limitations, of course. The global response rate, 223 countries and territories were invited to respond, but the response rate was 58%. 125 countries responded in round 3 and at least one other round. So the response rate was highest in the African region, in the Southeast Asian region and the Eastern Mediterranean region, as you would see on the table on the right. There were lower responses in higher income countries like Americas and European region and parts of the Western Pacific. So if you look at this graph, clearly the response rate from the, well, this table shows the global and regional response rate in the first round, in the second round, and in the third round. And clearly the European region dropped out highest from the third survey and also the Western Pacific. But the data for the global data, the Africa region possibly was the best maintained response. So countries reported disruptions across HIV and health, reasons and responses across the health system. And this graph is interesting because it shows the perceptions of levels of disruptions and recovery in communicable diseases. And what is highlighted is the hepatitis B and C diagnosis and treatment responses from 61 countries. Nearly half the countries, 46 of them, are back to pre-pandemic level, while 31% of the countries report that there's still disruption, but much better than the earlier part of the year. A proportion remain disrupted and have no change. And of course, some were even worse than the previous quarters of the Pulse survey. So going quickly on what next, where do we go from here for viral hepatitis? What are the next steps to closing the gap and achieving elimination of viral hepatitis? And as is written here, we're going back to our norms and standards. And right now, the new global health sector strategy for viral hepatitis, HIV, STI is being developed with some differences based on the changing environment and the COVID-19 recovery. And then a consolidated hepatitis guideline is in the works. Country support will resume and has been going on virtually in the past 1 year. And we're looking at developing and implementing costed and focused national hepatitis plans to support countries. And of course, expanding the country capacity to monitor progress, supporting countries to build on opportunities that emerge from the COVID-19 response. And there's always need to strengthen advocacy and collaboration and partnership. And I know that Northwestern is very research oriented, and There's always room for partnerships, for research, for modeling, for implementation science, for expert advice and expert support to countries and ministries of health, and definitely worth exploring possible collaborations. And I'm going to stop right here and say thank you for the opportunity to present this past 30 minutes. I look forward to questions, comments, and some of your thoughts and reflections on how we can learn more from the ongoing pandemic, or perhaps your experience in HIV, to support the development of integrated hepatitis programs. Thank you very much, Rob, and over to you.
Well, thank you very much, Funmi. Great hearing all the wonderful work that you're doing there at WHO. On the last point you just made, and we have at least one question in the chat, and I invite any participants to put your question in the chat or the Q&A, either one, we'll see them. But how coordinated is the hepatitis program with the HIV program? I mean, the HIV program is pretty well established, has a considerable amount of funding. I imagine quite a bit more than hepatitis. But is there any coordination going on with that?
That's an excellent question, and a key question going forward. From the WHO level, one of the things we're doing is trying to integrate or have significant strategies between HIV, hepatitis, and STI. And the new global sector strategy is going to document that. But on the ground, in countries, the HIV vertical programs remain vertical. And in many countries, we're exploring the benefits of having hepatitis B and C within HIV programs. And we're looking at some of these low-hanging fruits, one of which is the triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B using the same platform. Another low-hanging fruit is in harm reduction sites, where this is already being done in several countries, where harm reduction and hepatitis C are going hand in hand. One of the integration markers or indicators now is the prevalence of HCV in patients who have HIV. We're looking at micro-elimination of hepatitis C within HIV programs. We're also looking at diagnostic integration. We're looking at integration across procurements, across some of the logistics, and hopefully also the finances. But as you know, with HIV, many of these structures are vertical. Many of the donors are quite focused on HIV, and it is a barrier we need to work with going forward.
I mean, it seems especially logical with hepatitis B with overlapping therapeutics. We've got a couple questions. Let me ask. We have a question from Marion Peters, hepatologist here at Northwestern. What percentage of hepatocellular carcinoma in sub-Saharan Africa is due to HBV, HCV, or other etiologies, and how much does it differ between the countries?
That's also a very exciting question. In the study that I had showed earlier, about 50 to 70% of liver cancer are related to hepatitis B infection, while in some countries, 20 to 40% are related with hepatitis C infection. And the pattern of burden of hepatitis C is quite diverse in Africa. There are some hotspots of hepatitis C, while some countries have much more hepatitis B. In parts of Central Africa, hepatitis C prevalence is significantly more than in parts of Western Africa, and these changes are seen in different parts of the region. An example, of integration is Rwanda. In the Rwandan health system, in the healthcare, there's a lot of integration between the hepatitis and the HIV programs, and they are really a champion country for integration. So other etiologies in Africa, of course, we know that there are other causes. We know about aflatoxins, and studies have shown that there's synergies between hepatitis B and aflatoxins, especially in Gambia. We know about the non-alcoholic fatty liver disease and alcohol. Just that teasing all of these out for independent attributable fraction has been difficult in many parts of the world, and of course, even more so in Africa where the data does not exist. I hope that responds to some of that question.
Yeah, great, thank you. How about Lifeng who says, any specific efforts for HIV-infected hepatitis patients in your portfolio?
Well, what we're hoping is that funders of HIV program will work with hepatitis. For example, funders like PEPFAR and Global Fund have allowance for managing hepatitis C within those patients who have HIV, hence the concept of micro-elimination. There's very little allowance for hepatitis B, as tenofovir is part of the first-line therapy in many regions. But due to the changing profile of first-line therapies, I think we're going to need to have hepatitis B testing in all of our HIV samples and programs. So harm reduction, like I said, now also in PrEP, pre-exposure prophylaxis, the new guidelines recommend testing for both hepatitis B and C in PrEP users. Those are areas of possible integration for HIV programs and hepatitis.
Yeah, and Anna Yang asked basically the same question. What are some lessons learned from HIV programs that you could put into your strategies addressing these hepatitis inequities? Sounds like you're doing.
Yes, there are, it's like as if HIV really is a precursor for many of the lessons we're learning. HIV is showing us that public health approach can be done. It's showing us the need for decentralization. Part of the hepatitis challenge is that a lot of care is in tertiary and specialized center, and really scaling up the public health approach requires a lot of training, decentralization, changing of health services, even the reporting mechanisms, using the mechanisms of HIV that are very well entrenched in country surveillance. And all of those will support the scale up of viral hepatitis.
Great. Adeboye Ogunshaitan asks, have public health measures to reduce COVID-19 infection rates resulted in unintended or welcome reduction in hepatitis B or C rates? Have you been able to
again, that is a very interesting question. I mean, we haven't really delved into the details of intended or unintended, but some suggestion is that the injections in the vaccination scheduling and even the testing may really be a source of unintended, unsafe injection to promote the hepatitis B and C infection. Of course, we do know that people who have hepatitis B and C are worse off and they tend to have higher mortality than those who do not have. But I guess, and there are now some studies actually that are doing COVID-19 surveys that are including hepatitis B and C in their generalized surveys for COVID-19. So we await further results from that. And we probably would look closely to see if there are any intended or unintended effects of these co-infections.
Great. Ravi Javeri says, thank you for this talk. Given that HPV birth dose rates are still very low, given that we know tenofovir works to interrupt HPV transmission, and given that tenofovir is available in all countries because of the HIV programs, how can we better incorporate HPV testing and treatment into prenatal care in Africa?
Again, that is a great question, and one of the things I've highlighted. And there are certain studies in Africa now, one from DRC Congo, various others from Mozambique, that are pioneering the service delivery of antenatal testing, coupled with maternal prophylaxis if the viral load is high, and birth dose for targeted birth dose or universal birth dose. And those programs are nested in HIV programs and show clearly that it is beneficial, that it increases the vaccination of the newborn, and that it can be done. Some countries like Namibia in the Africa region would routinely test over 90% of their pregnant mothers for hepatitis B. So the momentum is gathering for what we call triple elimination. And in the last year, WHO has developed validation guidance and certification for triple elimination of these three infections. So yes, I would say the momentum is really getting work to speed it up.
That's really super great to hear. Okay, we have a question from Kara Palamountain. What innovations in diagnostics do you think are needed to meet the 2030 goals of 90% reduction?
All right, of course, that's an excellent question. And just to add that for hepatitis C, in the past few months, the HCV self-testing has been, the guidance has been released. Pilot studies are ongoing. It's available already commercially. So such point of care technologies and such self-help technologies will certainly increase the number of people that are having access to these, to diagnosis. Other innovations, of course, for viral hepatitis B, we're looking at things like the RNA, the DNA testing, the point of care DNA. There's now the hepatitis B core antigen, and we would like to see how far that will go to ease the process of diagnosis and treatment. And of course, innovations in treatment itself, we're looking at things like TAF versus TDF. We're looking at the guidelines and the eligibility criteria. So there are lots of aspects that can be scaled up. And of course, we're looking for the cure, HBV cure agenda. If there's a cure for hepatitis B found, it will change the dynamics of the epidemic, as it has done for hepatitis C and its cure. Of course, hepatitis C vaccination, that will also help. And it's a major innovation going forward. Well, another aspect of this is service delivery. If we could change the service delivery models that work, that will actually be a great step in reaching elimination. And one of these that has been shown is integration. That will really also be a game changer, in addition to, of course, political advocacy and countries using internally generated fund or domestic funding for strengthening health systems. So there are lots of innovations that will lead us to elimination. I hope that responded to that question, that long question.
Yeah, it was a short question with a long answer. But I also want to put a plug in for our CTHAN grant, our Center for Innovative Global Health Technologies, and related to HIV, but it can include viral hepatitis, particularly with co-infection. There is a call out for 1 year, $100,000 grants at any level of development of any assay or anything related to HIV and all the complications of HIV, like tuberculosis, hepatitis B, hepatitis C, and we're looking for them. So Funmi, if you run into anybody that has a great project, you can have them apply. I'll make sure you have the link to the application. We have another question from Marion Peters. Do you have data on 24-hour birth dose HPV vaccine versus later birth dose? Does later birth dose, like in the first weeks or month, impact the child getting all the doses?
I think that's also a fabulous question. What we have seen are modeling studies of differing timeframes of hepatitis B birth dose receipt. And of course, it shows that those who have the birth dose within the 24 hours are much better off than those who have the birth dose on day 7. And it shows decreasing efficacy over time. And I guess I can get more information on the specifics of that and share it with Professor Peters, who is on the, I can see the question here. So this will be great as well, because there are many questions to birth dose. As you know, in Africa, only about 14 to 15 countries have birth dose. Many countries have been, they've had their pentavalent vaccination for several years, for nearly 10 years. And many of them are questioning why they need birth dose. So we have to build the evidence for birth dose. Some countries think that since they have such a good pentavalent vaccination schedule, they may not need birth dose. So there's a lot of work needed on birth dose. And again, to add to this, the prophylaxis of mothers who are hepatitis B positive, the effect of tenofovir prophylaxis, the effect of tenofovir prophylaxis and prophylax all, rather than just women with high viral load. So there are lots of permutations and combinations that require further evaluation. But I do know that modeling studies are going on, and they may be the first to give us answers to those questions.
Great. Kate Kine put in the link to the grant announcement in the Q&A box there, if anyone is interested. A couple more questions we have time for. Geneva Fofana from Bamako. I think it's more of a comment. She says, well, this must explain then why the slow integration of the vaccination at birth for hepatitis B in West Africa region, especially since there's this missed opportunity to test women. I think you've addressed that already, but any further comment or?
In fact, some cost effectiveness study has shown that the cost of testing may be a lot higher than the cost of birth dose. And we do know that some countries have a higher prevalence than others. So I think it's going to have to be tailored to the country context.
Yeah. Okay, last question then. From Claudia Hawkins, what are your thoughts about current research being done in the field of hepatitis B virus cure and newer therapies? What recommendations would you make to ensure that the countries with the highest burden of HBV benefit from research and new treatments in development?
Claudia has asked a fabulous question and an extremely difficult question.
Yeah.
I think
it's a difficult question here.
I am quite excited that the interest in finding hepatitis B cure is gaining momentum, and that is really good. And we're hoping that in the future, with the hepatitis B cure, it will certainly change the face of that pandemic. I think your question was, how do we ensure that more research goes on in hepatitis B endemic areas? Yeah. How will we make sure that if there's a cure, it is going first to hepatitis B endemic areas? Those are highly political questions, depends on the farmer, depends on government, depends on global will. And I will give an example. For example, in the hepatitis C epidemic, the development of DAAs and the quick development of generic medication has led to over 10 million people being treated within 1 decade. This did not happen with HIV. It took several decades to get care to the common man on the street. So political pressure is very important in new drugs, new drug developments, making sure that the drugs get to the people who need it the most. So we're still going to count on the global north, working with the south for the advocacy that these drugs need to get to those who need it the most. And of course, here we're looking at pharma companies and working with pharma companies to get generic medications. I think I only partly answered the question, but there's so much to discuss in getting the medicines and the research to the countries that need it or have the highest need. I hope that answered some of that question.
I think as good as possible. Hey, thank you very much, Funmi, for taking the time to share your insights and expertise with us today. Thank you also to the audience for joining us and submitting your very thoughtful questions and making this a lively discussion. We invite you to join our next installment of the Institute's Friday seminar series, which will continue March 4th. We'll be joined by Dr. Henry Doctor, also of WHO, for a talk on strengthening health information systems. And thank you again for joining us today. And for those that have registered, a recording of the webinar will be shared via email shortly. And this includes today's webinar. And thank you again, Dr. Lesi, for taking the time to participate and be with us today. Thank you.
Thank you. Thank you very much.